UK, London, from the Fetal Medicine Foundation. I have got many accreditations, almost all of them, as well as the Advanced Fetal Medicine course from London, UK. And also, I did a 1 year training with Society of Fetal Medicine of India. And now I'm practicing as the lead fetal medicine specialist in JCC. So, without further ado, let us start with the topic. I'll be sharing my screen now. So, I hope you are able to see the screen.
Yes, we can, doc. We can.
Okay. So, the topic for today is fetal aneuploidy screening. And this is a very important topic, be it as a general radiologist or you do subspecialty in fetal medicine or any other subspecialty. This is something you will be coming across again and again. This includes topics like nuchal translucency and other sonological markers and also soft markers for aneuploidies. So, what is aneuploidy? Aneuploidy is altered number of chromosomes. So the number of chromosomes is extra or reduced, such as in trisomy or monosomy. Trisomy includes trisomy 21, that is Down syndrome, 18 Edwards syndrome, 13 Fetal syndrome. Monosomy XO, Turner syndrome, triploidy, and sex chromosome related aneuploidies. So, what is the impact of these aneuploidies? So, the aneuploidy can lead to miscarriages, fetal demise, that is intrauterine fetal demise, stillbirth, that is the baby is born dead, or neonatal death, that is within 28 days of life, the baby can die. If the baby survives, the baby can have mental retardation and other disabilities and infertility. So that is why it is important to diagnose the aneuploidies as early as possible so that the parents will be mentally prepared, psychologically as well as emotionally prepared for what is coming. Now, there are two things we can do to diagnose the aneuploidies. One is screening tests and another is diagnostic test. Diagnostic tests such as chorionic villus sampling and amniocentesis can confirm the diagnosis of aneuploidy. But for doing this, we have to make the patient to undergo an invasive procedure. Although the invasive procedure has only a small risk, that is of to 1%, that is up to 1% risk of miscarriage or limb reduction abnormalities. This 1% risk may be small for us as doctors because we want to confirm the diagnosis. That is what's important for us. But for the mother, it becomes a very big issue because it's the question of life and death of her baby. So, this is why to avoid the invasive tests, first we subject the mothers through a screening program in which we separate the mothers into low risk as well as high risk. So only those who have intermediate to high risk, they are subjected to invasive testing, and those with low risk are they can be the invasive test can be avoided in such candidates. So how do we do the screening tests? This involves a combination of several things, such as starting with maternal age. Every mother has a risk that her baby may be born with an aneuploidy. That is the a priori risk of the mother. A priori means prior risk, that is the inherent risk which exists already. So this maternal age is combined with ultrasound markers such as nuchal translucency, nasal bone, ductus venosus flow, tricuspid regurgitation. Earlier we were using frontomaxillary facial angle, and hepatic arterial Doppler, which are no more used. Plus, along with the maternal age and sonological markers, we also do biochemistry. This biochemistry can be done in the form of double marker, which involves free beta HCG and PAPA, triple marker, which involves these biochemicals, as well as quadruple marker, which involves AFP, beta HCG, unconjugated estrol, and inhibin A. So this is what we are doing in first trimester, then triple or quadruple marker in second trimester, and also the sonological soft markers, which are seen mostly in second trimester, but can appear in first trimester as well as later in third trimester as well. So a combination of all these gives the risk of the mother, and how we stratify the risk and what we do when there is low risk, intermediate risk, high risk, that we'll see later. So among these tests, the most commonly used protocol is a combination of maternal age, NT, and double marker, which gives a detection rate of 90% with false positive rate of approximately 5%. If the other sonological markers, NB, DV, and TR are added to this, then the detection rate improves to 95%. So there are other biochemistries such as triple marker and quadruple marker. Triple marker is commonly performed even today by many obstetricians in the second trimester after 14 weeks. But triple marker has a very low detection rate of approximately 70%. And according to international guidelines, the screening test should have minimum detection rate of 75% to be an acceptable screening test. So the triple marker is not a good screening test and should not be performed. Rather, we can perform quadruple marker in second trimester, which has a detection rate of approximately 80%. And then mostly in the second trimester, we'll be seeing these soft markers. We'll discuss what are the various soft markers which make up the genetic sonogram later in this presentation. Then apart from all this, there is NIPT or NIPS, which is nothing but cell-free DNA detection. This test also has its own pros and cons, which we'll be discussing later. So with all these things, this was the summary of how we are going to screen and why we are going to screen the baby. And if the screen test comes positive, it doesn't mean that the baby is abnormal. It only means that further investigation is required. So these are the various detection rates which I already mentioned in the previous slide. Now coming to nuchal translucency. So we saw here that first thing is the inherent risk of the mother, that is the age of the mother. And next we combine this with ultrasound markers, and the first and the most important among them is nuchal translucency. So what is nuchal translucency? On ultrasound, we see a black area which represents fluid on the back of the neck of the baby. This black area, this layer of fluid, is known as nuchal translucency. So this nuchal translucency should be measured with a lot of precaution. What are all the precautions, or rather prerequisites, which should be met in order to measure the nuchal translucency accurately? Accurately in the sense, even minor deviations in measurement of nuchal translucency can have severe impact on the results. For example, if you are not measuring it in the mid-sagittal section and the image goes slightly oblique, and this gives slight reduction in the nuchal translucency, and even a 10% reduction in the measurement can reduce the detection rate of aneuploidy by 60%. So that has a great impact on aneuploidy detection. So what are the things we should keep in mind while measuring nuchal translucency? The first thing, the crown rump length of the baby should be 45 to 84 millimeters. or this corresponds to the gestational age of 11 to 13 weeks 6 days. The next thing is fetus should be in neutral position, that is the head of the baby should be in line with the spine of the baby. If the head is hyperextended, then the nuchal translucency will be falsely increased, and if the head is hyperflexed, then the nuchal translucency will be falsely reduced. So the next thing which we should keep in mind after the neutral position, when the baby is neutral position, try to acquire a mid-sagittal section. The mid-sagittal section is defined by the tip of nose and the palate anteriorly. This is the echogenic thing which you are seeing here. This is the tip of nose, and this echogenic bar-like thing, this is the palate. This should be seen anteriorly. And then the diencephalon, this hypoechoic area here should be seen in the center. And the nuchal membrane, this is the nuchal membrane, this should be seen posteriorly. These are the things which define a mid-sagittal section, and in this section, we have to measure the nuchal translucency. If minor deviations are there, then these landmarks will be missing in the image. So the next thing we have to keep in mind is the magnification of the image, which should be such that the fetal head and the upper thorax should occupy whole of the screen. The next prerequisite is that the amniotic membrane should be separately identified. While you're doing the scan, just first you try to identify that what you're measuring is actually the nuchal translucency. Trace this nicely and see that the amniotic membrane is separate and you're not measuring the distance from the baby to the amniotic membrane rather than the nuchal translucency. The next prerequisite, the calipers should be accurately placed. Accurate placement of calipers means the horizontal limb of the caliper should be on the nuchal membrane along the margins of the nuchal translucency. Horizontal limb should be flush with the margins, on to on, neither in nor out nor anywhere other place except exactly on the margins. That is the only correct placement of calipers. Moreover, the measurement should be taken very vertically, as in this image. It should not go oblique. And then the next prerequisite, the widest anti-measurement should be taken. That is, you can take multiple readings if you have doubt which is the widest part here. And then whichever is coming the maximum reading, that should be taken. That is the widest part of the nuchal translucency. For example, here it is narrow, here it is narrow. This should not be measured. The widest part should be measured. Another thing to keep in mind is turn down the gain. Reduce the gain to get better image. Otherwise, you will get some fuzzy margins here. That is the slice edge artifact, which make you falsely reduced measurement. So always remember to turn down the gain and then take the measurement on a clear image. The average of measurements of anti above and below cord should be taken in case of cord around neck. This is a common thing, there will be cord around neck. So in such situations, take measurement above the cord and below the cord and take the average of those measurements as the nuchal translucency measurement. Finally, the anti-scan should be performed by certified individual in a controlled environment. That is, quality assurance monitoring should be performed whether the scans are done properly, whether the image is acquired with all these prerequisites fulfilled. So that is how the nuchal translucency should be recorded. So I have some my own observations in this. I have this habit of making my own observations, describing my own techniques. So, for example, in fetal echo, I have described several techniques, and even in this nuchal translucency, I have made some observations. For example, so many people have described what is a mid-sagittal section. Mainly the nuchal translucency maximum the attention is given to mid sagittal section and neutral position. So these two things I have made some observations. Mid sagittal section, they are describing so many things to identify what is a mid sagittal section. But just if we use our common sense and think, what we are seeing here is mid sagittal section of the baby's head and neck. So what is in the mid sagittal plane of the baby's head? It is the falx cerebri, this membrane what we are seeing here. So it's very simple to identify and get the mid sagittal section, provided the baby is in also a proper position. The falx cerebri should be seen. If the falx cerebri is seen, we can be sure that this is a mid sagittal section, and we'll get not only the hypoechoic diencephalon, you'll get this hypoechoic area behind the diencephalon, that is the intracranial translucency. If the plane is not mid sagittal, then instead of this falx cerebri, you will start seeing the lateral ventricles and the choroid plexus. In such a situation, the intracranial translucency, only a part of it, that is the partial volume, you will be getting here, and the NT measurement will also be reduced in such situation. So this is a very good landmark, the falx cerebri. And nowadays we have so high resolution machines, these things can be very easily seen on the scan. So that is one of my observations. And another thing is the neutral position of the baby. So neutral position of the baby, what we are using is head should be in line with the spine. Another way to decide neutral position is to see this maxillary bone. The maxilla, the width of this maxilla, just imagine it here between the chin and chest of the baby. So if this width, this much space is there, that means this is neutral position. If less than that, the chin touching the chest, that is hyperflexed. If wide space is there, that means the head is hyperextended. So this is how we can also decide whether the baby is in neutral position, and another way of falx to decide whether it is a mid sagittal section or not. Now, what is normal nuchal translucency, and when we say it is abnormal? So, traditionally, more commonly, what we are used to is the 3 mm cutoff. We have to be careful about this cutoff because it's not always 3 mm which is abnormal. For example, you can see at a CRL of 50, for example, 2.34 is also abnormal. It is above 95th percentile. So rather than 3 mm, it is better to use such percentile charts and see which percentile the NT falls in. The other way is to use the fetal medicine softwares such as Viewpoint, Aster, Sonocare, FMF software. These give you the percentile of the NT, but also give you a complete risk stratification by combining the maternal age, the PAPE, beta HCG, NT together. Also, other sonological markers like NBTR, DVPIV can be added to the software to get a more comprehensive risk assessment, and the likelihood ratios of soft markers, or just if within the software there will be options to enter which soft markers are present, which are absent, and that can also be integrated later in the second trimester. Quadruple test, if we are doing in second trimester, that can also be integrated. So the softwares really make the work very simple. So these are various ways how we decide whether the nuchal translucency is normal, abnormal. What does the thick nuchal translucency mean, and how do we manage the thick nuchal translucency? So, increased nuchal translucency doesn't always mean aneuploidy. If the nuchal translucency is 3 to 4.5 millimeter, then there is 90% chance that the baby may be euploid, that is normal. If further increase in nuchal translucency 4.5 to 6.5 millimeter, then there is 80% chance that the baby is euploid. While if there is gross increase in nuchal translucency of more than 6.5 mm, then there is only 45% chance that the baby may be euploid. That is, there is more risk of the baby having aneuploidy. So the more the nuchal translucency, more the risk of baby having aneuploidy. Now, not only aneuploidy, thick NT can also mean other major anomalies such as cardiac defects, diaphragmatic hernia, exam follows, body stroke anomalies, skeletal defects, other genetic syndromes like congenital adrenal hyperplasia, fetal echinacea, deformation sequence, Noonan, Smith-Lemli-Opitz syndrome, and spinal muscular dystrophy. Now, this shows us that whenever a thick NT is seen in the same NT scan, you have to do a detailed anomaly scan as well. That is an early anomaly scan. And of course, the iterational anomaly scan at 18 weeks onwards, that also you will be doing. But in the same NT scan, 11 to 13 week scan, make sure to do the complete fetal anatomic survey to rule out any associated anomalies. Now, the thick NT, apart from anomalies and euploidies, can also be an indicator of miscarriage, hydrops, IUFT. So that was about nuchal translucency. The next sonological marker is nasal bone. So for nasal bone, also just like nuchal translucency, we have some criteria. If you check all these features in this image, this is basically the same image which we used for nuchal translucency. That is CRL 45 to 84 millimeter magnification, head and upper thorax occupying the entire screen. Mid sagittal view, baby in neutral position. Now, after all these prerequisites of having a proper mid-sag view of the baby, properly zoomed and magnified, we have to angulate the probe along the baby's nose, in line with the baby's nose, and then slightly tilt the probe from one side to another side, 45 degrees or 135 degrees, and then you will be able to see the nasal bone. So not just keeping the probe in the midline, but angulating and tilting the probe side to side. That is when we see the nasal bone. So you can see here there is this hyperechoic line here, and there is this hyperechoic line here. So which one is the nasal bone? So none of this. The nasal bone is this third hyperechoic area here below these two hyperechoic. So to identify the nasal bone, you should be able to see three hyperechoic lines. The upper hyperechoic line is the nasal skin. The second upper hyperechoic line is the tip of the nose. And the third one, which is below these two hyperechoic lines, like an equal sign, this one is the nasal bone. So when do we say nasal bone is present or nasal bone is absent? What is the criteria? So the echogenicity of the nasal bone can be either similar to the overlying skin or less than the overlying skin or more than the overlying skin. It is only when the echogenicity of the nasal bone is more than the overlying skin, then we say that the nasal bone is present. If it is same or less, then we can give it as absent nasal bone. Sometimes when we are doing an early anti-scan around 11 weeks, then you may not be able to see the nasal bone. So just wait for 1 week and do the follow-up. Most of the times you'll be able to see the nasal bone in such cases. Even at the follow-up, if you're not seeing, then give it as absent nasal bone. Like this. You're seeing here the echogenic skin and all, but you're not seeing the underlying nasal bone. That is absent nasal bone. Next sonological marker is the ductus venosus flow. So trace right from the umbilical cord insertion. So what we did in the NT and NB images, we zoomed the head and upper thorax. For ductus venosus, we have to magnify the fetal thorax and the abdomen of the baby to occupy the whole of the screen. And then put on your color Doppler to demonstrate the umbilical vein right from the site of cord insertion and trace it to the fetal heart. Along the course, you will see this yellowish area of aliasing. So put the power Doppler, the pulse Doppler gate over here, and the sample gate size should be 0.5 to 1 millimeter. And angle of insonation should be less than 30 degrees. and then take the reading here. When you get the waveform, make sure that the filter is low frequency, 50 to 70 hertz, and try to increase the sweep speed. That is, when the sweep speed is less, there will be many waves overcrowding the screen. So increase the sweep speed to get a clearer picture of the waveform. What happens is when there is overcrowding of the waves, there will be false impression of the absent A wave. The waveform you can see it is having S, D, two peaks, and the third in between the two waveforms there is another filling up, that is the A wave. So just increase the sweep speed, spread the waveform nicely to check the A wave. Now, the abnormal ductus venosus flow is when this A wave is absent here and becomes reversed, like in this image here down below, it becomes reversed. This is abnormal ductus venosus flow. So this is one way of assessing the ductus venosus flow, that is qualitative way. There is another way, that is the quantitative way. Just take the trace of this waveform and check what is the PI, that is PI for veins, and enter that value in the software, either FMF software or other softwares, and that will help in getting the risk stratification for the baby. The next sonological marker is tricuspid flow. So when the baby is in a stable position, and as you know, CRL is always the same for all sonological markers, 45 to 84 millimeters. Magnify the fetal thorax, such as the thorax occupies the entire screen. Take the apical four-chamber view. Check the tricuspid valve clearly. And color Doppler should not be used for tricuspid regurgitation because it can give unreliable results in first trimester. So better without color Doppler, put directly the pulse Doppler gate here and use a large sample gate like 2 to 3 millimeter because the tricuspid valve has 3 cusps. So we want to include maximum valve area here involving all the cusps. So for making sure that all the cusps are checked, just slightly keep moving the sample gate also and take like around 3 measurements to make sure there is no insufficiency of any single leaflet. The angle of insonation again should be less than 30 degrees as in the DV flow we saw. This is the interventricular septum. The angle should be less than 30 degrees to the interventricular septum. Then again increase the sweep speed to get a clearer waveform, 2 to 3 centimeter per second. That should be the sweep speed. So this is the normal tricuspid flow where the regurgitation you can see here is not even 20 centimeter per second. What happens in regurgitation is the tricuspid flow will show a jet of reversal, which is more than 60 to 80 centimeter per second, and it lasts for more than half of the systole. That is, you can see here, this is the entire systole. Sometimes you'll get just a linear jet here due to valve opening closing, but that is not considered as regurgitation. To call it a regurgitation, the reversal of flow of more than 60 centimeter per second should last for more than half of the systole. So this is about the tricuspid flow. Now, whichever markers you have got positive, the tricuspid regurgitation or the ductus venosus flow or the nasal bone, you can add all those things in your software along with the NT, and also just feed in the PAPE beta HCG values, the maternal age. Then the software has its own algorithm which will calculate and give you the risk of the baby. So that risk stratification can be as low, intermediate, or high, which we'll see in the next slide. Before that, let us discuss this non-invasive prenatal testing, or rather, more correctly, this is called NIPS, so non-invasive prenatal screening. This is a screening test only, not a diagnostic test. There's a lot of marketing behind this test, saying that it is very sensitive, very good for all trisomies and other chromosomal things also. But the thing is, it has been validated mostly for trisomy 21, that is Down syndrome. For others, it is little less sensitive, and it has a low false positive rate, and clarity of results is better. Um, Now, what happens in this test is we check the cell-free fetal DNA. That is the blood of a pregnant lady, the mother, contains not only the DNA of the mother but also DNA of the baby. This DNA is not the DNA present inside the nucleus of a cell, but rather when the cell undergoes apoptosis, it releases small fragments of DNA. We are talking about those fragments of DNA here. And most of the blood of the mother contains the maternal cell-free DNA and only small amount of fetal cell-free DNA. Now, this is amplified, and then the analysis is done in the lab. Now, moreover, this cell-free fetal DNA, although we call it fetal DNA, it is not exactly the DNA coming from the fetus. It is the trophoblastic cells, the placenta, which are producing this DNA. So sometimes the DNA of the placenta and the baby can be different, and that can give you a false positive, false negative results. Now, another thing, the another limitation of NIPT is low fetal fraction, which is nothing but a failed NIPT, which is strategically reported as a low fetal fraction or no result or no call. That is, the quantity of fetal fraction is very low, so the result is not available. So in these cases also will not get a result with NIPT. And moreover, false positive results are common in vanishing twin, maternal cancer, placental mosaicism. That is, placental mosaicism is what I just explained, that the fetal DNA is not actually fetal DNA, but the placental cells, which are from the apoptosis of which these DNA fragments are released. So they may be different from actual fetal DNA. So that will give a false positive result as well. And this is a very expensive test. Now, when NIPT is available, we are saying it is an excellent screening test, up to 99% detection rate with false positive rate of 5%. This is the kind of detection rate it has got. High sensitivity is there. So, when we have this test NIPT, so should we go for double marker test, or we can go directly for NIPT? So this is also a debatable thing, and it depends on the choice of the parents and the obstetrician what she wants to offer. Ultimately, we can just offer to the patient various tests, and the patient will decide what they want to do. Now, regarding the consensus of most of the experts, the direct use of NIPT is not preferable as compared to the combined test, because if in case the NIPT fails, that is low fetal fraction, this is usually common in obese patients, which are also candidates for difficult, in whom the invasive testing is difficult. So what happens? You go directly for the NIPT fails, then you try invasive, that also fails. So you're left with nothing. The time for anti-scan is gone, double marker is gone. So you have nothing to assess the risk of the baby. That is the reason why they say that doing the anti-scan, double marker, the combined test, that is a more contingent screening test. That is, there is you have something safety to fall on if your NIPT fails. So that is one argument, that better to do double marker in all cases, and based on the risk stratification from the combined test, we can go for NIPT if there is intermediate risk to the baby. If the combined test shows high risk, then we can go directly to the invasive testing as well. No, this is the risk stratification. High risk when it is 1 in 100, some make it 1 in 50, some make it even 1 in 10. So overall, if the risk is more than 1 in 100, then it is a high risk to the baby. Intermediate risk is 1 in 100 to 1 in 1000. Low risk is less than 1 in 1000. So what to do when we get the screening test result like this? If there is low risk, nothing to do, just follow up with ultrasound in the anomaly scan. And if there is intermediate risk, then this is intermediate risk from combined test. So in such cases, we can offer the patient cfDNA test, that is NIPT. If it is negative, then just go for routine ultrasound. And if it is positive, then go for invasive test. If there is high risk from the combined test itself, then directly go for invasive test, that is diagnostic test. Now we are saying here after this low risk and negative cfDNA, we are going to do ultrasound. So in the ultrasound, if we find out an anomaly, then what do we do? If we find only some soft markers, then what do we do? And if the ultrasound is normal, then what do we do? So in case there is an anomaly, go for an invasive test. So it is like when there is an anomaly, it means that the baby is abnormal. So there is no question of doing NIPT or any other screening test just to find out whether the baby is at risk of being abnormal. So when anomaly is there, you're sure okay, baby is abnormal. So directly go for invasive testing, that is at anomaly scan if you're seeing the abnormality. Go for amnio with cardio array like that and find out what is the chromosomal problem, or do an analysis for the genetic monogenetic abnormalities as well to find out the underlying cause for the anomaly association with chromosomal or genetic abnormality. If instead of anomaly you are just seeing a soft marker, then calculate the new risk. That is, each soft marker like ventriculomegaly, choroid plexus cyst, echogenic intracardiac focus, all these things have their own likelihood ratio. And the likelihood ratio is not just how much more risk it brings when it is present, but also each soft marker has a negative likelihood ratio. So just you have to use the calculator which is available online. Like multivariate analysis has been done for markers in second trimester. This study, if you search, then you will get a software for calculating the likelihood ratio. Or in the fetal medicine softwares, if you feed in which markers are present, which are not present, which are absent, then you'll get a summary of the likelihood ratio, and that is multiplied with the a priori risk. That is what we got from the combined screening, that risk, and the new risk is assigned. If the new risk group is high, then go for invasive testing. If still intermediate, repeat cfDNA. If negative cfDNA, then reassure the parent of low risk. So if the ultrasound is normal, then routine care. So many things we are discussing here: invasive testing, NIPT, combined testing, quadruple test, double markers, or neurological markers. So what are we going to do with the patient? Which one will decide to do? So it is not upon us to make the decision. We'll just offer, okay, these are all the options and which test can give what result. For example, if the patient wants to be very sure whether it is there, whether the aneuploidy risk is there or not there, the patient wants a confirmatory test to be done, then they can go for invasive testing. On the other hand, if the patient says, okay, I want a safe test, not a risky one where there is risk of miscarriage, then they can go for NIPT or the other screening methods. So it depends on the patient's choice. The patient will make the choice. We can just offer them the various options like a cafeteria approach. So when this is about the aneuploidy screening, one thing we should keep in mind: when the screen test is coming positive due to abnormal papae, the beta hCG is normal, NT is normal, only the papae is abnormal, then we have to remember that papae is a placental marker. So it can indicate placental insufficiency also, rather than an aneuploidy. So we should make sure that in the NT scan itself, we rule out preeclampsia also. That is, take the uterine artery Doppler, the main PI, and then feed it. For that also, there is a calculator, free calculator with Fetal Medicine Foundation is available for preeclampsia risk assessment, where we take the maternal risk factors, the mean arterial pressure, uterine artery PI, all these things together for pre-eclampsia risk assessment. And then later in third trimester, you can follow for fetal growth, biophysical profile, fetal Doppler. So this thing also we should keep in mind that not only the aneuploidy screening, it should always be associated with PAPE. So what all we are saying in the NT scan, not just the NT and BDR and DV and TR, but also we are looking at the baby's anatomy as well as preeclampsia screening. In the same scan, look for the cervical length to make sure that there is no chance of preterm delivery. Now, there are some special conditions like twins and IVF where the protocol is different. In these conditions, for example, in twins, the NT is very important rather than the biochemistry, which is not very specific. And NIPT is a promising tool in these cases, that is in twins, but not fully validated by studies as of now. And in IVF, the donor age instead of maternal age is taken into consideration. Biochemistry is very variable, very different, so not very reliable. NIPT is quite reliable in IVF, and also in IVF pregnancies, the ova may be subjected to the pre-implantation genetic testing. There are PGTs, can be PGTA, PGTM, PGTSR. PGTA is for aneuploidy, M for monogenetic disorders, S for structural rearrangements. So even after doing all these and then going for the implantation, there is a risk that the PGT may be false negative. So even during pregnancy, we have to go for aneuploidy screening and diagnosis, even if pre-implantation genetic testing was done. So now after all the risk assessment and all, we have seen one important thing to do is to check the fetal anatomy in detail in the NT scan itself. Earlier we are checking the detailed anatomy only in the anomaly scan. That's why we used to call the NT scan as the level 1 scan, where we just used to see for the open spina bifida, such kind of things, neural tube defects. That was the only some gross things we used to see. That's why it was called level 1, and anomaly scan was called level 2. But now these terminologies should not be used anymore, because in first trimester itself we are seeing the detailed anatomy of the baby. So you will see here what I'm doing in this video, just holding the probe, letting the baby to move around, and just acquiring the clips. So this is a very easy way to screen the baby's anatomy. We are seeing everything, the hands, the fingers. We are getting the mid-sagittal plane for the NT, the NB we are seeing here, the brain we are screening, the lungs we are seeing. This is the axial view of the head. Then we are getting premaxillary triangle, the hands, no diaphragmatic hernia. The entire anatomy we are able to screen just by taking some clips. The lower part, the legs, the bowel, no echogenic bowel, the limbs are okay, movements are okay. Then this is the another clip. See here the spine, the hand, the fingers. We are able to see entire anatomy of the baby just by taking few clips. The heart is also seen here. These images, the spine of the baby, the leg and the foot of the baby, the hand, the fingers. These are all the images from the same clips which I showed in the previous slides. See the cord insertion, no omphalocele, and the premaxillary triangle, both nasal bones are present. Sometimes single nasal bone may be absent, and that will not get this completion of the triangle. So all these things we can check in the NT scan itself. In this video, I'm showing the fetal heart at the time of NT scan. We are able to see the 4-chamber view, the 3-vessel view, 3-vessel trachea view, the entire axial cranial sweep we are able to acquire and delineate the different parts in NT scan itself. Okay. So that was about the first trimester scan. So earlier, they used to do only the NT and leave rest of the things for later pregnancy, the anomaly scan in the second trimester, and more of the detailed things in the third trimester. This was the thinking before. This was known as pyramid of care of pregnancy. But later they found that most of the things like preeclampsia, aneuploidy, anatomy, everything can be detected in the anti-scan itself. So they inverted that pyramid of care. So what we follow now is the inverted pyramid of care for pregnancy, where we do most of the things in the anti-scan itself. Now, another thing is the sonological soft markers. So, as described just before, that there are various sonological soft markers, the likelihood ratios of which are calculated, which is absent, which is present, and then the risk is adjusted according to presence or absence of the soft markers. These soft markers are not abnormalities, but they can indicate the presence of aneuploidy. Now, for example, ventriculomegaly is one of the soft markers. This is the cerebral lateral ventricle at the level of the atrium, the parieto-occipital sulcus. Here we have to measure the inner to inner distance of the ventricle. That is, in NT, we are keeping the caliper on the margin. Here we have to keep along the inner part of the margin, in to in. So if it is less than 10, it is normal. 10 to 15 is mild. More than 15 is severe ventriculomegaly. And it is the mild ventriculomegaly which is mostly associated with aneuploidies, while the more severe ones are associated with structural abnormalities, infections, and such things. So what is this? These are choroid plexus cysts. Again, very common to see this. So if you are in a practice where you're doing like 15 to 20 ultrasounds, obstetric ultrasounds daily, then these soft markers and anomalies are some things which you have to see in your daily practice. Day to day, you have to keep seeing these things. If you're not seeing, then you're just missing these things. So this is choroid plexuses. They can be unilateral, bilateral, unilocular, multilocular, small, large. So it doesn't matter. These are very safe things and very less risk associated with aneuploidy also. And usually by 26 to 28 weeks, they will resolve. Then the nuchal fold thickness in the axial section of the fetal head at the level of cavum septum pellucidum. We take this section, the transcerebellar plane, behind that is the cisterna magna, and this thing from the outer margin of the occipital bone to the outer margin of the overlying skin. This is the nuchal fold thickness, which should be less than 6 mm. More than 6 mm is associated with risk of aneuploidy. And the cystic hygroma, when there is too much edema and fluid around the neck of the baby, the jugulodigastric sacs are dilated. Then you get this kind of large collections. This entire thing is cystic hygroma. Baby is only looking small in front of the fluid collection. So it can have septations, it can be without septations, it doesn't matter. Both are having a high association with aneuploidy. So in this case, we can see there is anasarca also, diffuse edema all over the baby's body, even cysts are forming even around the abdomen. There is a layer of ascites also here. And this is the case of absent nasal bone, which we discussed before also, how to identify presence and absence of nasal bone. Aberrant right subclavian artery arises distal to the left subclavian artery and traverses behind the trachea. Around 85% of the times, that is most of the times, it goes behind the trachea. And sometimes, like 10%, it can go in between trachea and esophagus. So very rarely it comes anteriorly. But most commonly, the best way to see is go and take the three-vessel trachea view. And there, if you're seeing a vessel going behind the trachea, that is the aberrant right subclavian artery, which is having a high association with risk of aneuploidy. Echogenic intracardiac focus can be small, can be large, can be single, can be multiple, can be univentricular, can be biventricular. Overall, their association with aneuploidy is a little bit less. And just to look for any other abnormalities in the heart, although they say echogenic focus is not associated with cardiac abnormalities or aneuploidies, it is very less risk thing. But often when we see cardiac anomalies, we see this echogenic cardiac focus also present in there. So we need to revise the studies also and do some different kind of study for this. For example, in this case, we are seeing pericardial effusion, we are seeing ventricular septal defect, and this was actually a case of tetralogy of Fallot. You can see the overriding of aorta straddled across the in that VSD, subaortic VSD. So that is the echogenic intracardiac focus. And choroid plexus cyst, I think I have not told you the size criteria for that. So the minimum size for choroid plexus cyst should be 2 to 2.5 mm. Larger than that is the choroid plexus cyst. Otherwise, it can be just normal cystic spaces within the choroid plexus, which are very tiny. So we should not confuse it with that. Now coming to the next soft marker, the fetal renal pyelectasis, renal pelvis dilatation, more than 4 mm in pregnancy less than 28 weeks of gestation, and more than 7 mm dilatation after 28 weeks is known as pyelectasis. So if there is gross dilatation, for example, before 28 weeks, it is more than 7 mm, then we classify that as a UTDA 2 to 3, that is urinary tract dilatation, antenatal 2 to 3 category. So those kind of things are mostly associated with obstructive uropathies, while the lesser ones, the milder ones, 4 to 7 before 28 weeks and 7 to 10 after 28 weeks, these milder categories of pyelectasis are associated more with aneuploidies. So next is the echogenic bowel. We call the bowel as echogenic when its echogenicity is same as that of bones or more than that of adjacent bones. So what I am doing here is just I am turning down the gain completely, and then slowly I am increasing the gain after fully putting it down. And when we are increasing the gain and we start seeing the bone, at this point nothing else should be seen. But if we are able to see the bowel, like in this case, along with the bones, that means the bowel is echogenic. Echogenic bowel can be a marker of aneuploidy with good association of risk with aneuploidy, or it can be due to cystic fibrosis or intestinal obstruction or marker of FGR. So we have to rule out all those things accordingly. This is a single umbilical artery. Normally you see two arteries on either side of the bladder, but here we are seeing only single umbilical artery. Again, high risk of aneuploidies and also high risk of cardiac abnormalities. So whenever you see a single umbilical artery, also do a fetal echo to rule out associated cardiac abnormalities. Short long bones are having relatively less association with aneuploidies, such as short humerus, short femur. This can also be due to fetal growth restriction. So only when the shortness is less than 5th percentile, it actually the term short long bones can be used. Otherwise, like if it is more than 5th percentile but coming towards the lower side, you can just follow the patient for FGR rather than aneuploidy, or just leave the patient alone and do a routine follow-up. So that was all about the aneuploidy screening and soft markers. Hope this will be helpful for you all. Thank you so much.
Thank you so much, Doctor. Any questions or queries from the PGs? Anyone has any question? Okay, then, Doc, first of all, thank you so much for the wonderful session, Doc. Your expertise and the knowledge is really evident in every aspect of your talk. And I'm sure our PGs also found captivated by the words from the beginning to the end. Really appreciate for taking out your busy schedule time and also putting so much effort to, explain everything in detail. Thank you very much, Doc. We look forward for
Thank
the
you
next
very much for
opportunity to learn.
inviting me. Yeah, thank you, Sana. Thank you for inviting me. The privilege is all mine. Thank you so much. Bye bye.
Thanks, Doc. If there is anything, any query or anything, we have a WhatsApp group, Doc. So if I get any question from there, I'll get in touch with you.
Sure, sure. We also have a WhatsApp group here in GCC for especially for fetal medicine from consultants who are interested in it. So,
Okay.
so yeah, we can share across the queries. We can answer them. No problem. We'll have the discussion on WhatsApp also.
Sure. Thank you, Doc. Thanks a lot.
Thank you.
Thank you
Thank
all
you.
for
Bye bye.
joining. Thank you. Bye.